Mike Williams, and Pulitzer Prize-nominated Jenifer Goodwin. This 60-minute webinar is presented by the Abaris Group, a consulting firm that specializes in ambulatory care, emergency department, trauma, EMS planning, program implementation, and financial analytics. We are really glad you've joined us today. We have a really large audience also, with pretty much every quadrant of the country represented, including Alaska. Let me go over some housekeeping issues. If you need technical support during the call, please call our webinar provider, GoToWebinar, at 1-800-263-6317, and follow the prompts for technical support. We welcome your questions during the webinar, and to submit one, type it in the designated questions area in the control panel and click Send to submit. We will answer questions over the audio system and not on the computer screen. In addition, the webinar is being recorded and will be uploaded to the Abaris Group's YouTube channel, where you can find other webinars that we've presented. And finally, the 2013-2014 Ambulance Industry Report is available for purchase. At the conclusion of today's webinar, your browser will be directed to our secure website in order to purchase the report if you so desire. Now let me tell you a little bit about our authors. Jenifer Goodwin is an award-winning writer, editor, and researcher with over 20 years of experience working for consulting, marketing, and publishing firms. As associate editor of Best Practices in Emergency Services, Jenifer has written extensively about the EMS industry, including reimbursement issues, the impact of healthcare reform, and changing delivery models. Her interviews and analyses have been published in leading EMS and public safety publications, including GEMS, EMS World, and the Journal of Emergency Dispatch. A former staff writer for the San Diego Union Tribune, Jenifer has won numerous national writing awards and was nominated for a Pulitzer Prize. Our other author, Mike Williams, is the president of the Abaris Group and has 35 years plus in the operation and design of emergency care systems. He is a specialist on health reform with respect to pre-hospital, outpatient, and inpatient hospital services, and on regional delivery systems at the safety net and traditional payer levels. He has been a speaker for the American Ambulance Association, the California Ambulance Association, Fire Rescue Med, and the American College of Emergency Physicians ED Reimbursement Seminar. In addition, he has been frequently asked to consult for the Advisory Board on ED issues and is an editorial panel member for the publication ED Manager. Jenifer and Mike, we're glad you could join us today.
Oh, thank you, Juliana. I'm happy to.
Thank you very much, Juliana.
Now let's get started. Mike, why don't you tell us why the Abaris Group decided to start writing the Ambulance Industry Report in the first place?
Well, the Ambulance Industry Report goes back. By the way, greetings to all of you, and thank you, Juliana, for that introduction. Very much appreciate Jenifer's participation today. It really began about 15 years ago when the ambulance industry itself was going through so many changes that there literally was a website that tracked, okay, who bought whom, and trying to keep track of that was very challenging, and more importantly, we never heard the whole picture. We just saw anecdotal acquisitions and mergers and what have you. And so we chose to create a vehicle, the Ambulance Industry Report, to report on the entire industry. And so we've kept that up to date periodically over the last 15 years.
Excellent. And Jenifer, why don't you tell us why it was so important that we write or release this 2013-2014 Ambulance Industry Report now?
There's a lot of interesting things happening right now, both within the EMS industry and the wider healthcare space, that are having repercussions for EMS. One of the big events was the emergence of the healthcare reform movement, and specifically the passage of the Affordable Care Act in 2010. Healthcare reform is fueling very rapid change in the healthcare industry. A big trend is tying reimbursement to quality of care rather than quantity of care. The overall goal, as many of you are probably very familiar with, is moving away from a fee-for-service payment model and instead rewarding care that's both cost-effective and high quality. For a long time, EMS has been reimbursed through a strictly fee-for-service model, and that is still true for the most part. But lots of EMS industry leaders and other healthcare industry observers believe that change is coming and that EMS will at some point be expected to show that the services provided or its interventions actually are working and that they're cost effective, and the reimbursement is going to be tied to that. So those trends are leading more and more EMS agencies to take a hard look at the way that they provide care, the types of services they provide, and their financial models to get prepared for what they see as this almost inevitable change that's on the horizon. A lot of them believe at this point that the strategy of basically asking Congress to hike Medicare and Medicaid reimbursements is going to fall on deaf ears. There's just too much political pressure to rein in healthcare costs. So the conclusion of many of the great minds in EMS is that what the industry needs to do is find ways to use its 24/7 mobile resources and its trained workforce to bring greater value to the healthcare system as a whole, and most importantly, to position itself as part of the solution in controlling healthcare costs and improving patient outcomes rather than just another cost driver. So from the perspective of the ambulance industry report, with so much happening, it seemed like the right time to examine these trends and changes and how it's impacting and potentially impacting EMS in the years to come. I would like to take a moment to thank all of the people in EMS who took the time to share their insights with me so I could write this report. I personally learned a lot in doing the research, and there were some very experienced people that really shared some great insights, and it was very obvious in doing the interviews that there's a lot of people in the industry that have great ideas, that they care very deeply about the profession, about the patients, and the EMTs and paramedics they work with. There's just a couple of other key trends that I'll mention that we cover in the report. Those include the impact of the recession on EMS. The recession put pressure on governments at all levels, from municipal to federal, to control spending. There's an increasing emphasis on bringing evidence-based medicine to EMS, and growing use of technology that's making data collection and that sort of performance tracking more possible than it's ever been before. And there's this growing awareness and acceptance in the EMS industry that EMS may need to adjust its business model and rethink its delivery strategy to accommodate all of these changes.
Well, that is, appreciate the excellent summary there. And all of that information is covered in the ambulance industry report. Now, why don't we move on to the first major question that we have, and that is, what is the size and scale of the EMS market?
So EMS is often referred to as a fragmented industry. So it's delivered by lots of different types of providers. They don't yet have great ways of sharing information one another or a central database to store information, although they're working on that. But because of that, it's been a challenge for the industry to gauge its size. So far, the best attempt at doing that is a report called the National Emf Assessment, which was released by FICOMS, the Federal Interagency Committee on Emergency Medical Services, in 2011. The assessment itself was led by researchers at University of North Carolina, Chapel Hill, and it relies on data that was collected from a number of sources, including the National Association of State EMS Officials. So the basic findings are, as of 2010, there were more than 22,000 EMS agencies nationwide. There were 81,000 EMS vehicles of all types. EMS responded to 37 million calls for service. Not all of those resulted in transport, though. About 28 million resulted in transport to an emergency department. There's 826,000 EMTs and paramedics and 8,400 medical directors. Now, another good look at the size of the EMS industry is from the Government Accountability Office, the GAO. They issued a report in 2012. The general rule of thumb that was shared with me by the American Ambulance Association is that About 50% of ambulance transports are for Medicare patients, 10% are Medicaid, and about 20 to 30% of patients have commercial insurance. The remainder are self-paid or uninsured. And those figures can vary from place to place depending on the characteristics of the population served, such as the median age or the socioeconomic status. So the point is that Medicare patients are a big part of the business. And according to the GAO, ambulance services provided 16.6 million ground ambulance transports for about 5.1, so just over 5 million Medicare beneficiaries in 2010. And the Centers for Medicare and Medicaid, CMS, reimbursed ambulance providers about $5.2 billion for those transports.
Excellent. Mike, do you have anything to add? Well, let's move on to the next question.
I do as soon as I unmute myself. Sorry about that. You know, what gets muted must get unmuted if you're going to hear, if anybody's going to hear you. I was just going to do a quick workup. If it's $5 billion spent by Medicare, you can easily get to a $100 billion expenditure program per year for the industry in general, and the reason for that is, you know, we're not talking small potatoes here, folks. We're really talking about something that should be reckoned with as it relates to the kind of leverage we have. We often think also in terms of ambulance patients having the ability to leverage other costs in the healthcare system as well, and those actually have never been formally articulated in a scientific article. But our thinking is that while EMS delivery represents about 1% of the expenditures of healthcare in the country, and that has been marketed and researched, it probably drives for that particular EMS patient somewhere close to 40 to 50% of the expenditures for these patients when you think of the necessity of transporting the patients to an emergency department, the potential that in the emergency department a lot of tests will be ordered whether they're needed or not, and lo and behold some of these patients get admitted, and we're now learning from Medicare in particular, and through some of the national initiatives, a lot of patients need to be admitted. So you can see scaling, this type of scale gets scaled up considerably when you look at the overall impact on the industry.
Yeah, Mike, just to add to that, I think it was JAMA that the study came out in, although I'm not 100% sure, where researchers were basically pointing to that fact. I want to say the study came out that even though EMS direct cost to Medicare is about 1%, there is this growing awareness outside of the industry. So, you know, hospitals, emergency departments, insurers, that because EMS is making that first patient contact and making some decisions in the field about where that patient is going to grow or is going to go, that they actually end up, you know, potentially impacting downstream costs far more than the 1% would indicate.
Well said, and that's what I well.
Juliana, are you there?
Juliana, I think we're ready for your second question.
Yeah, are you?
I'm here. Can you hear me?
Yeah, we can.
We can.
Okay.
Yeah.
Great. Who are the large players, and what is their status?
So the two biggest private ambulance companies in the United States are American Medical Response, AMR, and Rural Metro. And in doing the research for this, there's a lot more information available about AMR because it's a public company. So in August, Envision Healthcare, which is AMR's parent company, held a very successful initial public offering. and according to forms filed with the Securities and Exchange Commission, AMR estimates that it has about a 7% share of the total ambulance market and a 15% share of the outsourced ambulance market. In 2012, that was about 2.8 million transports in 40 states. Its fleet includes 4,400 vehicles operating out of more than 200 sites. And what's interesting is if you look at that National EMS Assessment, which said that there were a total of 28 million transports annually, so if AMR is taking care of 2.8 million of them, if I'm doing my math right, that means about 1 in 10 people were transported by an AMR vehicle. The story with Rural Metro is a little different. Just a few days before AMR's IPO in August, Rural Metro is its rival on a lot of the RFPs, or at least they were until recently, filed for Chapter 11 bankruptcy protection. And according to court documents, the reason cited by Rural Metro for doing this was excessive debt and an overly optimistic prediction of how much billing revenue they'd be able to bring in. The last I read, Rural Metro had its bankruptcy emergence plan okayed by the courts. This was back in December. And the basic plan was that Rural Metro would exchange equity in the company for debt forgiveness. So I do think it's worth noting that despite Rural Metro's financial troubles from a clinical perspective, it's my impression that both AMR and Rural Metro are companies that are very respected for doing a good job in the communities they operate in and putting an emphasis on clinical excellence and some innovative programs targeting specific patient populations who are maybe over-relying on the 911 system and emergency departments for their care. That said, AMR is definitely a company to keep an eye on. They're doing some really cool things, and they're starting to get some national attention for the work that they're doing. One of them was in 2012, AMR received a $1.5 million grant from the Medtronic Foundation's Heart Rescue Project, which has the goal of improving sudden cardiac arrest survival rates in the United States by 50%. In participating in that, AMR is in good company. Other heart rescue partners are some of the nation's leading resuscitation experts at University of Arizona, University of Minnesota, Penn, University of Washington, and I think there might be several others involved as well. AMR's clinical leadership is also heavily involved with industry efforts to promote the concept of mobile integrated healthcare, which is basically partnering ambulance providers with other healthcare providers such as hospitals or primary care doctors, even social services or other sorts of community partners to deliver other types of care, just transport to emergency departments for 911 calls. The goal is to improve outcomes for patients and also to realize cost savings for hospitals, insurance companies, accountable care organizations, or CMS. So AMR is really trying to do some innovative things, and it's going to be really interesting to see what they come up with and how that develops in the next couple of years. Now, Mike, I know that you had mentioned that there were some developments with AMR's IPO or stock offerings. Do you know what the latest is on that?
Yeah, Envision has announced the parent entity of AMR has announced, and they run also other businesses, including a very large emergency medicine staffing group. They've announced a secondary public offering that would generate about the same revenue, and the prices have been divulged, and so they were so successful. I think the first round, they went to the second round. And I do want to mention that we mentioned AMR and Rural Metro, which I believe will be emerging successfully from bankruptcy as a stronger company. But there are other major players in the country, and then just a gaggle of what I would call mid-sized players that do an excellent job and serve their communities extremely well. And so none of this is to be inferred as the report concentrates strictly on those two players.
No, and in the report we also talk some about the role of, of small ambulance companies and small providers. Did you want to talk about that at all?
Well, I mean, I think by inference, they are the bread and butter behind the capability, and it's a little hard to speculate what AMR is going to do with all this cash that they get from the two offerings. But one of the obvious opportunities might be to go back into the merger business and acquire some of these players. But many have turned down similar offers in the past, and they continue to do an excellent job in their communities. So all of which are well represented and documented in our report.
Mm-hmm.
Shall we move on to the next question?
Yeah, I mean, I think the only thing that I might add to that about the smaller providers is the really key role that they play in so many of their communities. And while there are these big companies that are able to do a lot because of their size and the resources that they have, in a lot of communities, the EMS provider is very much an integral part of the community. The community relies on them, and they have a very, very important role in providing EMS in this country.
Great. Shall we move on to the next question?
Sure.
Where do you
Sounded like you cut out there, Juliana.
I'm sorry. I should mention that GoToWebinar, our webinar provider, is having some difficulty with audio at this time.
So can you hear me? Because I can go ahead and get started if you can. So what's happening to response time standards? Was that the question, Juliana?
Yes, well, it was.
Okay. So this is a super interesting topic that, Mike, you and I have talked a lot about. So I'm going to start off maybe by talking about some of the few interesting developments that have happened, and then maybe, Mike, you could weigh in as well. So, response time standards are basically requirements that responders arrive on scene within a set amount of time. And I'm only just giving this brief background for anybody that's on the call that's not in EMS. So with private ambulance contracts, response times are set in the contracts. There's penalties for not meeting them. And response times can vary based on the acuity of the call or the area where the call is coming from. So, you typically have longer to respond to an outlying area than in a sort of more urban core. And for a very long time, response time standards have been the main way that the EMS industry has measured performance, and they still are. Recently, that indicate that there may be some change brewing, and that response times may not be the sole measure of performance forever. So within the EMS industry, there's been some studies and papers written that are seeking to define which calls are really time sensitive. So in the calls in which that life or death or other types of patient outcomes which can be harder to measure, such as length of hospital stay or long-term disability and so on. So one of these important papers was issued in December 2009. The National EMS Advisory Council published a report called EMS Makes a Difference. And researchers looked at 400 studies of EMS that were done over 20 years. And the report identified specific call types that are clearly time sensitive. Those include STEMI, stroke, respiratory emergencies, trauma, and pediatric shock. But the authors acknowledge that those represent a relatively small portion of all the calls that ambulances actually respond to. So what I take from that study, it was an indication that the EMS industry is starting to look at those questions, such as under what circumstances does it make a difference if an ambulance gets there in 8 minutes or in 10 minutes? So over a couple of years, response times have come up in ways, and specifically in a few areas where major contracts have changed hands. And those include Santa Clara County, California, Alameda County, California, and EMSA in Tulsa, Oklahoma City. So in December 2010, AMR lost the Santa Clara County contract of rural metro. And not long after rural metro took over, the local newspaper, the San Jose Mercury News, started reporting that rural metro was having difficulty meeting response times. This eventually led to the county sending letters to rural metro that it was in breach of contract failing to meet response times during certain time periods. In September, the Mercury News reported that rural metro was trying to cut short its 5-year contract because it's losing $5 million a year on it. And according to people that I spoke with in the EMS industry, the Santa Clara contract reportedly had very stringent response time standards that would be very difficult to meet with the current resources. So another situation emerged in Alameda County, and there's similarities to it. AMR had lost the contract to Paramedics Plus, also in 2011. Alameda County is a big contract. It covers 1.5 million people in the East Bay, San Francisco area. Alameda RFP included much more complicated and stringent response time standards than were required under the previous contract. And in the bidding process, AMR basically told the county that in order to meet those response times that they were asking for, they'd have to add lots of resources and charge much more than they used to. In their bid was much higher than Paramedics Plus, and they lost the contract. So Paramedics Plus took over, and they promptly started losing money. In September 2013, Paramedics Plus told counties that they had lost $21 million during the first 2 years of operations. And the reason for the loss, according to Paramedics Plus, was twofold. There was a dramatic shift in payer mix from commercial insurance to Medi-Cal, which is California's Medicaid program, and that led to a reduction in revenues and collection. The other reason was large fines that they were facing for what would be considered in the industry relatively minor response time violations, and this was due to these overly complex response time metrics. So in October, Paramedics Plus told the county what was going on, and the Alameda County supervisors approved ambulance transport base rate hike and a mileage increase. They amended the contract. It also reduces some time fines and simplifies the response time metrics that they were having trouble meeting. So Paramedics Plus says that their financial picture in that area is going to improve greatly because of these amendments. So I'm wondering if you want to weigh in here. I know when we were writing this, you have a lot of experience with RFPs and with these sorts of contracts. And so how unusual is it for a major company to either want out of a contract, like in Santa Clara, or for a county to agree to change its contractual terms midway through the term of the contract?
Question, Jenifer. It's highly unusual. I think is probably the best way to describe it. I'm not suggesting, as I look back, if there are any other examples that it's never happened. But, it's a symptom of a real and the notion that we at least have a little leverage in this industry by pointing to changes in payer classifications and adjustments, because we do know that employer-sponsored insurance is a euphemism for Blue Cross, Blue Shield, Health Net, but those that is purchased from an employer are employer purchases for you shopping as less and less employers keep that insurance, or being changed and adopting the new health reform insurance, which have different benefits. By the way, ambulance and emergency departments are in fact have very clearly mandated requirement under health reform under the Accountable Care Act, excuse me, the Affordable Care Act, as is psychiatric care, by the way. Mental health is required. Having said all that, I think these requirements and the adjustments and changes are unusual. They're so unusual that the state of California, we have a model in this state that the state has an office and there are 33 local EMS agencies, but there are some things that report directly to the state on, some things that report directly to the local government entities. And one of the areas they report to the state on is what the ambulance franchises look like, and what when they get through a change process, they're supposed to be approved by the state. And the state has notified both counties, or at least one of the counties, that the adjustments that they have made, it does require them to go back out to bid immediately. So there's a level of discussion going on over that. So that's a question that really rises. I want to actually get back to the policy point here as well, which is the whole just what's happening with response time standards. And I think you're seeing we are on the cusp. We have not seen any dramatic changes, but we are on the cusp of people asking tough questions. Does response time make a difference? And the general answer is, as tough as it is for us to see it this way, and I think many of us believe it, including many people on this call, it doesn't make a lot of difference. And so if you were able to get the citations from the EAGLES conference, the conference of EMS medical directors across the country, you'd see some science and some literature that suggests that study after study, not only the actual time of response does not matter, but whether response times really mattered at all. And I think this is going to be a significant public relations problem, because if you go to any community and you study this issue and you talk about response times or adjusting them, or, boy, if you got really tricky and risky out there, eliminating them or reducing them in deference to some other types and quality outcome standards, which is really what health reform is asking us to do, you're going to have a complete insurrection. It's properly set up. So it's important that we understand that this trend is occurring, and that that it's likely to pick up steam, and people are going to be asking questions, not the least of which is payers are going to be starting to ask questions. Did you make a difference? Was the service needed, or what have you? So, simple things are going to be simple. Does every unit, and including the first responder, they all have code 3? Well, the simple question is no, they don't. Now, once they're there and committed to a call, are they completely committed? Can they take another, baby not breathing 1 block away call? Well, that's likely not done in most communities, and yet it would be an appropriate triage of that resource. And again, that's not about response times, that's about meeting that specific need. So I think we're really questioning these response times, and we're pushing hard on them. It's very difficult. Our firm's involved with several large in California EMS systems where we might recommend changes, but it would be hard for us to make a wholesale change right now, given the appetite for the public and the embeddedness of what response times really looks like. Fortunately, the state of California has, I believe, get the number here, 26 outcome standards that begun to develop, and I see that some of those could replace some of the response time standards. Looking for more details on what do we do with these cardiac patients, with these brain patients, with these trauma patients, and does their outcome improve if we're going to transport them to a longer, distance away medical facility. So it's a long-winded answer, Jenifer, to your question. Yeah. We want to get out this policy question because it's a significant one. It's going affect our ambulance franchises in this country profoundly in the next 5 years.
Yeah, I would like to add one thing to that. I think you bring up really good points, including the public relations issue. So sort of one of the third thing that's happened around response time, some of these contractual changes, was in October, AMR won the contract to provide EMS service in Tulsa, Oklahoma City. The EMS system there is known as AMSA. Paramedics Plus had held the contract previously. So AMSA's contract, AMR, with its new provider, actually extends the allowable response times for priority on urgent calls from 8 minutes 59 to 10 minutes 59 seconds. And AMSA's medical director has, publicly said and written a letter on this and talked to his community and talked to officials there that decision is based on scientific research that shows that increasing those response times will not compromise patient safety, but it would save a lot of money. So for a call like a heart attack or a cardiac arrest where 9 minutes is already too late, it's those first 4 to 5 minutes that are going to impact whether someone lives or dies. Responders, so typically the Tulsa Fire Department, would still be getting there before the ambulances to start defibrillation and CPR. So I think if you look at these several things, the studies, what's going on in Tulsa, some of the things going on in Santa Clara and Alameda, I think you start to get the beginning of some indications that the EMS industry is starting to come to this conclusion that the old school way of considering response times above all else may be outdated, and given financial constraints not entirely reasonable. But like we said, the response times are definitely not going away anytime soon. There really is not an agreed upon way of measuring other types of performance. So there needs to be a lot of work done on determining what other performance measures, what interventions, are proven to impact patient outcomes relative to the cost of providing those services. The industry isn't there yet, but I think it's really intriguing just to see some of the things that are going on that people are starting to talk about and question. So, yeah.
It is extremely interesting, the changes, especially with the response time and moving away from that. Why don't we move on to the next question, which is what RFPs have been conducted recently and when in the future?
Mike, do you want to take that one?
Yeah, why don't I start in case anything jiggles out, Jenifer, you can add to it. Pending RFP right now are City of San Diego, and honestly I cannot tell you whether they're out to bid or they're close to being, but they're one of the two. I say close in 2 months. And the incumbent there, Rural Metro, all of your ambulance players have indicated an interest. I was involved in preparing that RFP. I believe there's a smaller RFP in the county or in the Central Valley of California called Merced that's going out soon, and that's a very small county. There'll be interest from a couple of players there, an incumbent as well. The Board of Supervisors and Riverside last week decided not to go to bid. That was a question that had been raised during a study we've done, and they've chosen to stay with the incumbent there for a significant period of time in the future. So that bid did not occur. There's some other potential bids in California that are pending, but they need a lot of public policy work to make that happen. We just had the Tulsa bid, and that turned over again back to AMR, Tulsa, Oklahoma City, and we know that communities that are within 2 years or so of having RFPs prepared would be Contra Costa County, which is east of San Francisco, and also Portland, Oregon is a couple of years out from having to prepare a bid as well. Those are the ones that come to mind.
We move on to the next question. What about health reform, ACA, and its impact on the EMS industry's future?
So, I think this is a question as well. There are some direct and some indirect impacts. The direct impacts are that more people are going to have insurance, and so presumably more people are going to be able to call an ambulance to go to the hospital. This could be a big deal revenue-wise. The uninsured are a big drag on revenues for ambulance providers. As just one example, in 2012, about 18% of AMR and MCare, which is their sister company, about 18% of their patient volume was self-paid, which is many of them are uninsured. And yet those patients accounted for only 4 to 5% of the revenues collected. So there are some, big issues with collecting with that patient population. So what financial impact health reform is going to have on EMS, though, is still being sorted out. Because many of those with insurance are going to be receiving coverage through the Medicaid expansion. Medicaid is less than Medicare and less than private insurance. And ambulance companies say that Medicaid doesn't even cover the cost. And there are definitely some early indications that ambulance providers are seeing more Medicaid patients, and the privately insured are becoming a smaller portion of the payer mix. Although, we'll say this does not, figures, this doesn't count for what's going on when people enroll into health exchanges. So in September in JAMA, they looked at data from 2005 to 2010, emergency department visits by California adults. And during that 5-6 year period, they found that ED visits increased by 13%. A lot of that was fueled by Medicaid patients. ER visits rose by 36% for Medicaid patients, 25% for uninsured patients, only 1% the increase was fueled only 1% with private insurance. So now, again, those numbers only go through 2010, so what's happening with the health exchanges and what that's going to do for coverage is still playing out. I think the overall issue and the overall question that is, that again is still unclear is as healthcare is making the shift in focus from fee-for-service to a system of care that emphasizes improving patient outcomes and lowering costs, what is that going to mean for EMS? EMS is still working out how they're going to make that shift, what direct impacts it's going to have on them, when it's going to start directly impacting them. Also, the very cool thing is there are some innovative EMS agencies that are beginning to make that transition. Mike, did you want to add anything? I know this is an area that you've looked you've looked at closely.
Yeah, we actually have worked in 3 communities now where we've actually calculated down to very small micro grant what the payer impact is going to be on EMS before or after a midterm, which we think is now, and then the latter part when there's full maturity of health reform, which we consider 2019. And as you said, the self-pay and uninsured is going to go likely down in these communities to a very, very small amount. I think the big question is, I believe that the EMS industry is in for a bit of a boost in that. And by the way, about across the country, about 54% of those that are going to be insured under health reform are going to be insured using a very what I call commercial-looking product, a Blue Cross, a Health Net, depending on what state you're in and what forms approved, and the remainder would be a Medicaid-type product, and so you pay basically like a Medicaid patient. By the way, Medicaid payments vary state by state, so sometimes it's actually a pretty liberal payer. It just happens to be in most states that we've studied, it's a very poor payer, but there are some states where Medicaid is not bad. So the big question becomes, what's the impact on the EMS industry? Well, first of all, I think on a short term, we're going to see more revenue. And the big question to ask, what are you going to do with all that revenue? Is that revenue that's going to be pocketed? Is it going to be used to and returned to the community for reform and innovations, or or R&D for some strong indicator? I think that maybe it's 3 years, maybe it's 4 years, is going to be outweighed by a major emphasis on reforming EMS, and you can already start to see it with the JAO report that came out in September, looking at waste and fraud in ambulance services, and also an appetite by some payers who are getting smarter and smarter to say, well, wait a minute, if you're 1% of the budget, but you control a lot of our patients, we're now incentivized based on outcomes, and a lot of these patients we don't want to come to the emergency department because they're likely to be admitted, and our emergency departments are overflowing. We're not going to pay you the same way as we used to pay you, and in fact, we might pay you not to bring patients, or in some countries, for example, across Europe, they're paid to respond, but they're not paid to transport. So there's a, just taking the Netherlands, for example, the mantra there is, pay them for the response, but don't pay any additional pay if they take to a hospital, and therefore their hospital delivery of patients is much lower than the United States. We 75% of our patients that we respond to, on average, get transported to a hospital, and theirs is much lower. So I would look for a early sort of gift basket of opportunity that is resulting from payers who are currently uninsured, will be converted to either a commercial product or a Medicaid product. And you might ask, well, which one is it going to be in my community? I don't really know. You have to do the math, and we'd be happy to help anybody with that. And then the question then becomes how much money, and we've done that in Riverside County. We've recently calculated a per dollar value and of a per run as to what that additional revenue looks like. And ultimately, if this is going to be short-lived, what are other alternatives? And there are other alternatives to look for innovations that don't pay us on a per transport basis, but really look at ways for us to receive revenue and some of these other innovations, which we'll talk about, I think, here in just a minute.
Mm-hmm. Very good. Let's move on to our medicine concept and its development for EMS.
Sure. So I think that this is a nice segue, Mike, from what you were talking about. So there's actually two new concepts that are getting a lot of attention and traction in EMS. One of them is community paramedicine. These programs are actually about a decade old. The first ones in the United States started in rural areas of Maine, Minnesota, and later on Colorado. And the basic idea was that paramedics with added training in areas like patient navigation, medication reconciliation, chronic disease management could use their 24/7 mobile resources that are already out in the communities to fill gaps in local public health and primary care services. So as the pace of healthcare reform picked up and community paramedicine programs started catching on, EMS providers in suburban and urban areas started realizing that a similar concept could fill gaps in their areas as well. In 2013, a group of EMS physicians and other EMS leaders coined a new term. It's mobile integrated healthcare, and this expanded on the concept of community paramedicine and is used to describe a variety of partnerships in which EMS is one of the partners, but could also include EMTs, paramedics, nurses, physicians, healthcare providers, social services providers, community-based providers that are all working together to improve patient care. So mobile integrated healthcare is a broader view, and the consensus that the industry is beginning to arrive at is that community paramedicine would be one facet of a mobile integrated healthcare program. So mobile integrated healthcare could include programs such as providing home visits for recently discharged patients to avoid unnecessary hospital readmissions, transports to alternative destinations such as mobile health care facilities or urgent care instead of the emergency department, or nurse advice lines to handle non-urgent 911 calls. I think this is a really exciting area for EMS. It's one that a lot of innovative thinkers and industry leaders are very interested in and are seriously pursuing. CMS is also interested in these concepts as part of their healthcare innovation grants, which are designed to test new patient and service delivery models to, deliver better care and lower costs. They gave out 3 grants to EMS agencies to launch community paramedicine programs. And the grants totaled about $13 million, and there were 3 locations that got them. It was Reno, Nevada, Pagosa Springs, Colorado, and Prosser, Washington. As far as I know, those programs have not yet started to report results, outcomes, although that is a requirement of the grant. So it's going to be very interesting once they start publishing, what's happened as a result of these programs. And last summer, I think it was July, August, CMS was taking applications for a second round of grants. I don't know if those have been awarded yet. I haven't heard the status on that. But again, there was a number of EMS agencies that indicated that they were very interested in applying for these and participating in these to start their own programs. The National Association of Emergency Medical Technicians, which is NAEMT, they recently spearheaded an initiative to create a consensus statement on mobile integrated healthcare and community paramedicine to define the core elements of these programs. This is a very important step. About a dozen EMS agencies and emergency physicians organizations either participated in creating this division statement or endorsed it. So it's a clear sign that this is something that the industry is trying to get behind in a unified way. There are some interesting numbers about what's going on as far as the number of programs or how big community paramedicine mobile integrated healthcare are getting. NAEMT did a preliminary survey of EMS agencies across the nation. They found that about 15% of EMS agencies indicated that they were developing community paramedicine or mobile integrated healthcare programs, and about 6% said that they already have programs in place. Characteristics of them, often the programs are targeting frequent EMS users, but some other types of programs that they're trying out are readmission avoidance, expanding access to primary care, and use of alternative destinations, and also nurse triage. So right now, many of these programs are operating as pilots or are funded by grants. Although really significantly, a few EMS organizations have entered into financial agreements with hospitals, hospice organizations, and other healthcare providers to start sharing in some of the savings for participating in activities like the readmission avoidance for patients with conditions like diabetes and congestive heart failure are very, very costly. So these organizations say that it still is a small part of their revenue, but they are very committed to them, and they absolutely anticipate that this is going to grow.
Very good. We do have some questions that I'd like to get to from the audience, and one of them is that what about fire ambulance providers and GEMT? How is that affecting the industry?
Mike, do you want to take that? I'm not sure that I'm getting the question. What about fire ambulance providers? I'm not quite getting what they want to know.
You know what, Jenifer, and Mike is having a little bit of audio trouble, so he's rebooting his system. But let's see if there's another question in here. We've gotten a few, and if we don't answer the questions over the on the webinar right now, we will answer them offline and then make them available to all the participants. But here's another question. Can you touch on?
I mean, the only thing that I can say about fire is that they're, you know, a critical part of EMS, and when we talk about EMS, we're talking about all types of EMS providers. Fire-based EMS agencies, I think the last number I saw, are responsible for something like 40% of, you know, of EMS responses. So, you know, there's been, because they've had a different financial model than some of the private ambulance providers, they have been somewhat slower to get involved with especially some of these innovative programs like the community paramedicine and the mobile integrated healthcare. But that is definitely starting to change. Again, a lot of the fire agencies are very interested in this. They're very interested in participating in providing this service to their communities. I know Dallas is a you know, big municipal fire department that they're actively getting involved with this type of work. So I think that if we're talking about, you know, innovations in particular, it's something that is happening through all, you know, all parts of EMS, and that includes fire-based, private, third service, you know, hospital-based, and so on. So it's not limited. It's definitely not limited to one segment of the profession.
And Juliana, I think you had a couple questions, and you have something to close, huh?
Great questions, and while we won't be able to answer all of them on the webinar because we're ending in a couple of minutes, we will answer these offline, and then I'll email the answers to everyone so that your questions are addressed and everybody can benefit from them. But one of the questions is, in your research, have you noted more hospitals getting back into the ambulance business?
And maybe I could take that one, Jenifer.
Yeah.
I would say the answer is no. Occasionally you'll see a critical access hospital who has a way of collecting on costs, get into the ambulance industry. We just finished a study for a hospital in California that's a critical access hospital. But other than that, I don't see them getting into the business, and there are no incentives to allow them to get into business. They don't have any ability to, beyond just the fee-for-service, to cover their costs.
You know, Mike, and I agree with you. I had kind of heard that, you know, that might be a trend that was going on. So I actively went looking, you know, doing every possible Google search and talking to people to see if I could find any cases of hospitals acquiring or taking over, you know, ambulance services, and I literally found nothing. I think I found not even one example. So I'd say the answer is no as well.
Great. Well, thank you so much, Jenifer and Mike, for spending an hour of your time with us today and discussing the ambulance. You all know again that the the report there available to purchase, and we sure appreciate your time today and your attendance, and look forward to seeing you again on another Abaris Group webinar. Thank you all very much for attending.
Thank you very much. This was fun.
Bye.
Can you hear me?
Bye.
Okay, take care. Bye-bye.